to Korle Bu, which is congested, and not go to Family Health or not go to away. So I think we need to learn from some of their ways. And maybe if you enter my consulting, you should come backwards and then move your shoe. You show me some respect and you be afraid and you take the medicine. So we need exceptional patient care, a cultural immersion. So it's good to come and see the traditional Ghanaian way, and it's one-stop, convenient travel. If the airlines reduce their fares, it will be even much nicer. It's even more expensive to travel in West Africa to come from London to Ghana. So we need to look at all that aspect as well. So a few case studies. I looked at fertility tourism. This is on the net, so this is what we need to use. First, top best fertility centers in Ghana. That's big. It's a huge business, and I hope the Society of the obstetricians are trying to handle this. I know people have come from Canada, from the US, to come and get this done. So the Bank Hospital is JCI accredited. I think they have a COHASA and the JCI accredited. So saying they are not the only private hospital in Ghana with international accreditation. So they've had their first kidney transplant. Again, this is something that once you have the technical know-how and expertise, we need to get on with that. They have, if you've been there, it's a lovely facility. So Ghanaians want a hotel, VVIP, C-suite, executive care, but it's not cheap. So you have to look at payment options too as well. Okay, so they have lots of facilities. So people are looking for a one-stop shop place. So you should have everything so that they don't move from place to place. If they don't have, you must have somewhere that you can send them to get it done. So these are some of their dialysis and new MRIs, CTs, and etc. So the specialties are plus cosmetic surgery too as well. So I see Dr. Obing here too as well. So we need to okay, so I've talked about their protocols, and again, patient testimonies is important. Once somebody gives you one bad, it's like a one bad granite in your mouth, then that's the end of you. So we need to work very hard at getting this patient experience going on. Your battery, okay. So how do you do? So they have a good logistic and travel arrangement. They arrive, it's a seamless process, accommodation, they have some flats nearby for patient relative, they have a good appointment scheduling, and the aftercare is also very good. So that's something we need to work on. So this is Albany, mainly an outpatient service, and we book people in advance. We have about 18 different specialties working there, so it's easy to So we had one of our testimonies. Somebody came from the UK, saw a neurologist, had an EEG, saw an endocrinologist, saw a GU surgeon, saw a vascular surgeon, saw everybody with reviews for a year. So we need to work on the interdisciplinary team working. So that's very important for us too as well. So move to my third case study. Focus has been with us for a long time. So the mission and vision and values are very important. Patients look at that. So they look at catchy words. So Focus's values are prepared. Passion, purpose, respect, excellence in performance, patient safety, attitude of trust, integrity, responsibility, and efficiency. So anybody who sees that will say, no, I have to be here. So the service and quality is an ongoing, continuous process which you need to look at. So we need to look at quality assurance and patient-centered care. For me, these are the two most important things. Continuous education, professional development will come. Facility and service maintenance is important. So painting, somebody comes to a facility, or the paint is peeling and the place is not clean. People want to see, I enter the place is clean. So we need to invest in our cleaning, in our cleanness. And these are little things that we overlook to make that. So also Focus has also a multidisciplinary service. Also, a very well-equipped surgical theater and ICU, and the aftercare is also excellent. And the ICU, so this to manage this is not cheap. So we need to know that going into this comes with a lot of financial cost, and we should be able to recoup our costs. We are not doing it for charity or for an altruistic cause, but we need to get it done. So these are some of the wonderful needs that have been done there. So my disclosure, I used to work for Focus from the beginning for about 15 years. So I'm still a very part of that. So you need to be affiliated with institutions. So Hospital for Special Surgery in New York sends patients over, and all the organizations send patients over. So, and we are training with the Ghana College and West African College of Surgeons. So that is a center of excellence to as well. St. Michael's Hospital is new, so they are also part of this process. I came to medical school tourism. It's very, very important. We have 2 excellent private medical schools, and this is also an opportunity for students to come in and see, when they come and see that we've had an experience here, and they go back and say, okay, why you need surgery, why don't you come down? So this is a unique opportunity for our medical exposure and linkage with the private centers of excellence. So it will be good. We will be very happy to have students coming to Albany or going to Focus for a rotation, and this is our society, so we need to foster our own. So that is something that I'll recommend as we go on. So in conclusion, experience brings world-class healthcare. Expertise, we have all the renowned medical professionals. Affordability, we have competitive costs. We need accreditation, so we need to work on JCI certified facilities. If we have JCI, then Bupa and all the other insurance will be happy to pay for their patients to come and do it in your facility. If not, then they have to pay by cash. Battery. Okay, so in summary, we've had a little summary of Ghana's potential in medical tourism, and I think it's huge. So the future outlook for us is to attract international patients, and there are many of them. And I'll tell you that a lot of them are not easy to deal with. They sometimes think they are coming to a lower class place, but when they come and they see what we offer and the things that we are able to do, they go back very happy with a change of mindset and want to come back. So I think the call to action now is for stakeholders in the healthcare sector to look at this next step. We need to advertise, we need to be compliant, we need to look for funding. So funding is a whole topic on itself. So we need to look at funding by itself. So I think we are doing very well as a society. Let's keep it up. And next low-hanging fruit is to get international patients. So thank you very much. So I think I acknowledge Bank, Focus Hospital, Albany, and the society for inviting me. Thank you very much.
Right, we've just had our first lecture, and probably we take the second lecture before question time. I hope I don't forget a lot of things that you said, very stimulating, and so during the question time, people will also raise some of these things. It's very essential that we do a lot of things that you said. In fact, one thing that you said, which I want to comment before I continue this, is collaboration. Collaboration and collaboration. And we in the private sector, if we can collaborate with each other, we can gain a lot. There is no use coming to my facility if there is some further facility in a friend's place. So we have to develop friendship too. When we develop friendship, we can make all this work. And in medical tourism, it's a very important thing to look at. We have everything in Ghana. so far as medicine is concerned, and especially private medical practice is concerned. But we are not looking at ourselves. We are not helping ourselves. We are not helping our friends. And this is becoming a problem. The problem because we want to go go elsewhere. Why should I go elsewhere if there is Albany, which they have endocrinologists and neurologists and all that fields, and the person lives at Hacho or North Legon. So I refer my mother-in-laws to that hospital. She can come to my place free, but I refer to that place. It's nearer her, and she has all the care. Why should I let cause be empty when I know that I have patients over there and I don't need to have them here? They also refer cases. I was doing that with Dr. Yemo, my very good friend and teacher, and it was perfect, you know. And in those days, when I was younger, I could go at dawn to operate with him and do so many things and get a collaboration. So I think the problem or the issue that he has raised about collaboration should be taken into consideration greatly. But what we need to do is to even know each other well and to help each other in so many fields. And if you have an opportunity to train, why not do that? As of now, I will tell you again that I have some friends coming to me yesterday from India, and they want to train people with certificates and all that. So really, I can keep that. I'm exhausted. If you have younger ones or you yourself, if you collaborate with me, I will let you go or send somebody to those places and they train and they come back. So, ladies and gentlemen, let's take this in very carefully. Collaboration is very important. Our next speaker is among us here. Yes. Okay. Well, we have promotional presentation by Das, DS, before the next speaker. And I think I'll wait after the presentation, then I will introduce our next speaker.
Hello, good morning. Good morning, ladies and gentlemen. Sorry, good afternoon. Good afternoon, ladies and gentlemen. My name is Michael Odami Asante. I'm a pharmacist with DAS PLC. As you all know, DAS is Danex Items Tower PLC. We merged in 2020 and now we are DAS PLC. We have a wide range of products. We have our ointments, our syrups. Okay. We have our ointments, our syrup. Syrups include Tida, Durol, the ointments. We have H-Tamol, Sulfur, so many products. And normally when we come to these AGMs, we want to highlight some of our products. And I think these products are products we were using in the past. So it's more of just a reminder that these products are still available. This is forward. This back. Okay. All right. So the first ointment we'd like to talk about is our Wakefield ointment. Most of you know I point this way. Okay, thank you very much. The first ointment I'd like to talk about is our wasteful ointment. So basically, our wasteful ointment contains benzoic acid and salicylic acid ointment. So we've added these two API, that's active pharmaceutical ingredients, to cater for fungal infections. So for any kind of tinea infection, it could be tinea pedis, tinea unguium, all those kinds of infections, you can use our wasteful ointment. And wasteful ointment is quite unique. Unlike the other fungal ointment or creams on the market, the benzoic acid kills the growth of the fungus, while the salicylic acid, that's the 2%, just peels the affected part off. So in chronic fungal infections, especially the allergic foot rot, you realize that when you use the plain miconazole, sometimes it's difficult. If you have a patient that sweats a lot, it's very, very difficult for them. But with our wasteful, it's very, very easy. And you get the results within even a day. A day after you use, you realize that the fungal growth of the infection is gone. And when you use it for about 7 days, depending on the kind of condition, for tinea unguium, that's all right, so for tinea unguium, that's in our local diet, we call it a caca. That affects the nail. For that one, you have to use it about 2 months. So some of the conditions are indicated on the board. So we have the lettuce foot. And we have the ringworm. So for all those kind of conditions, the duration you have to use is about 7 days. But due to the nature of the condition, the tinea unguium, that will take about a month or 2. And the application is very, very simple. You apply a thin layer on the affected part twice daily, and it could take, let's say, 7 days. And another caution about the wasteful is that with the salicylic acid ointment, it's quite strong. So people use it on their whole skin, not the affected part only. So when you use it on the whole skin, you realize that the normal skin will be peeling off. And that's as a result of the salicylic ointment working. So people think maybe the side effect of our wasteful ointment is that the normal skin will be peeling off. No. So you just use it on the affected part, and you'll be done with it. And we have the plain salicylic ointment. That's our jar with a blue top. So with that one, it's just plain salicylic acid ointment. And it's very, very effective against dermatitis and sometimes chronic dermatitis as well. The application is very, very simple. Peels off the affected part. So in case of fungal infections, normal dermatitis, you could use the salicylic acid ointment. The application is the same as the wasteful ointment. You apply a thin layer on the affected part twice daily, and for the duration of about 7 days, you get a required result. And we have our sulfur ointment. That one has a pink top, as shown in the diagram. And that one is very effective against acne and any acne-related infections, whiteheads, blackheads, pimples, all kinds of acne infections. And that one is very, very efficacious because it inhibits the growth of the bacteria that's causing the acne. And I know most of the time, some of our clients, they take in what we call triple action. And those creams contain corticosteroids, which are not really good for acne treatment. Sometimes it could even aggravate the condition. So we give our sulfur ointment. And sulfur ointment is also effective against scabies. For the scabies in kids, we use it for about 3 nights. So the child will use it all over the body for 3 consecutive nights. And also because the mice, they lay eggs on the bed sheet and stuff like that. You have to clear the bed sheet as well. The application is simple. You apply a thin film twice daily, morning, evening. The only caution with sulfur, as we all know, is our GCPD clients, or people who have hypersensitive skin to sulfur. They don't use sulfur. Apart from that, any of our clients can use sulfur. And the unique thing about sulfur is that when you use it on acne, it's very difficult for reoccurrence of the acne. And our next ointment we'd like to talk about is our calamine ointment. Most of you know the calamine lotion is the dominant one that we use on the market. But we have our calamine ointment. And I think with this ointment, it's more economical because with this one, you apply a thin film of the cream on the skin. It doesn't color the skin. You can actually have your clients walking out or walking in around with no one knowing that the person has used any calamine preparation on the skin. And it's as effective as a lotion. And it's even more economical because with the lotion, you use about a bottle in, let's say, 3 or 4 days. But with this ointment, you use it for about 2 weeks. And it does the same thing. For any condition that you have pruritus, itching, any associated condition with itching, you can use our calamine ointment, and it works the same way. And we have our H-Thermal. Our H-Thermal contains 10% of H-Thermal and white soft paraffin. With H-Thermal, it's very, very effective against boils. And this is one of the natural substances that has, let's say, a triple action effect: antibacterial, anti-inflammatory, and anti-fungal. It works the same way. And it's very, very effective against boils because it shrinks the boils and it doesn't let it spread. It's very, 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 very effective. The downside of it is when using it with clients with GCPD, you have to be cautious because sometimes they do react to it. And people with hypersensitive skin also. The application is simple, 1 to 3 times daily. And the duration for about 5 to 7 days, you'll be okay. And we do have, I think, one of our last ointments we'll talk about. That's a Ditranol ointment. And that one has a green top. The ointment jar with the green top. And that one is usually good for psoriasis and dermatitis and alopecia areata. Some people tend to have patches in their hair, as shown on the diagram. And this one prevents the T-cell activation, so it prevents the activation of the T-cell. So, and these conditions sometimes come about as autoimmune disorders, the body attacking itself. So by using the Ditranol, you slow down that reaction. So it also curbs and reduces the infection as well. And the application is quite simple. You apply to the affected part within 30 minutes to 1 hour. Ditranol is quite strong. It's been known that when clients use it above an hour and they don't wash it, it kind of affects the skin. This is not a known side effect, but sometimes studies have shown that it could cause some sort of dermatitis if you use it for a very, very long time on the skin. So normally we advise clients to wash it after an hour of use. At that point, it has already penetrated the skin and it's already working. And the last ointment on our slide will be the zinc oxide. Zinc oxide it has an antibacterial effect used for nappy rash, and people with bedridden sores is very, very effective. And for children as low as 1 year, they can all use zinc oxide. It also caters for dermatitis as well. And the application is very, very simple. A thin layer is wrapped on the affected part 1 to 3 times daily. And for the duration between 5 to 7 days, we are done. And I said our last ointment, but this is our Miconazole 2%. It's called Micotrain. It's plain Miconazole 2%. So for those who don't want the ointment and they prefer the creams, for the fungal infections, you could use Miconazole 2%. It's very, very, very effective. And as you all know, for all the antifungal, Miconazole is one of the most efficacious APIs for fungal treatments. And the application to is simple. You apply it 1 to 3 times daily on the affected part for a duration of 5 to 7 days. Thank you very much. I would like to end my brief presentation. And if there are any questions, I would like to answer them also. Thank you.
I think we'll take questions after. Thank you very much. Our next speaker is no other person but a known public health figure who has been in the ministry for a very long time. He's an epidemiologist with West African College of Physicians. He's been in health planning and policy development and analysis for a very long time. He has MBA, and presently he's the manager. He's a manager and a consultant for so many things. He also is a lecturer and has part-time lecturership with the University of Ghana and Mount Crest University. The most interesting part of all this is that he's a lawyer, and he did it very recently, and I'm sure he will use that to a great advantage. Ladies and gentlemen, I call on my senior colleague, Dr. Kofi Ahmed.
I think is Thank you. The theme is healthcare brain drain to bring in the role of the private practitioner. That's the whole thing about. That's what it's all about. It's from this society of private medical and dental practitioners. Thank you. Mm-hmm. This one. These are problems. This same, okay. Okay. All right, thank you. As I said, my topic is about public sector collaboration for the training and retention of health professionals. It's being forward and backwards. I mean, you know what? Now we are moving to AI. That's good. Even present AI, they are giving us a lot of wrong information, but we are still with it. Now, human one is somewhere here. It's supposed to be a video. we copied it. That way they have a problem with it. Yeah, this is not having a problem. We copied it. I'm giving the pen, but the copy is already. Okay, let me. Okay, I think we do away with the videos and then we just start as it is. Okay, now I say, what is migration? It talks. Migration is just about the movement of people from one place to the other. It's involving the change of residence. There are so many reasons why people migrate. And as you can see from the presentation, we have okay. People migrate because of things like some economic opportunities. There are some economic opportunities, or they have been sort of politically sort of persecuted. And the environmental factors, family reasons, and then educational purposes for research, etc. And other social reasons, sometimes moving to join the family, etc. All those things. Mostly these days we come out brain drain. Migration mainly has to do two mainly either unskilled labor or highly sort of trained people. And the highly trained people, that's what you call the brain drain, or what you call the human capacity flight. And that's exactly what is we are talk about the human capacity flight. That is the brain drain. Now, is it? Okay, I see. Now look at it. Why are people migrating? Why do people migrate? And then, in fact, the video would have given up, but we come up to that one again. There are so many types of migration. We have what you call the internal migration. Sometimes people moving from, in the whole country, for instance, people move from, one can say, maybe recently the Kayai, when they come in, one can say simply moving because of some development, something happened in the country, or even there's a war. People move from one place within the same country. It's internal migration. And then you have international migration. What is when you move across borders, you move across one border to the other, that's international. Then the rural migration, especially in our country where we are constantly everything in the cities. People move from the rural areas to the urban areas. And then the refugee migration is usually when there is something like conflict, and then the refugee goes into that, the person goes into that country. He leaves the country into that country while trying to get the paper here, and then he's a refugee. Once you're outside, you are no more. Then, of course, labor migration. Then we call the circular migration. People, they go and stay in for a long, then they move around, they come in again. These are sort of types of migration that we have in here right now. What are the effects of this mass movement of people, that's migration? We've got the social effects in the sense that where they go in there, different cultures here and there, mixing here and there, mixing their cultures, they can't really mix properly. And also those countries, even recently we heard that some countries, the people have started sort of, they're a bit hostile to the immigrants because they are affecting their social and culture here and there. But you might have heard about the Northern Scandinavia, a lot of the people from Southern Arab countries, and then when they went in there, their sort of culture mixing up with them, it becomes a social problem here. And in the country itself, it comes up to some other social problem as well. The main thing, one thing that they go about is that the effects of the migration becomes more like economic effects. And then the culture in the sense that they export their culture there, and they mix up in there a little bit. Some of them are not able to mix. After some years, they still, you can see some, they're still in a different country, but they are behaving as if they are in their country. This culture is here and there, this other. And then it changes the demography in the sense that we have the youth, mainly, the people, able-bodied ones who are strong, who are moving. Then we leave either the young ones or the old ones. In fact, recently, when whole families move, you leave only the old ones, and so there's a change in demographic structure of that particular place. And this happens in both the destination country and then the country where they are coming from, that's a host country. And then this happens. There's a change in all the social, economic, cultural, as well as the, the demographic patterns. Now, what I gave was just mainly about migration of people, in general. But now we talk about what is brain drain. And we talk brain drain is mainly because human capital flight. That is, the people, it's not as one of you would have told that it's not, brain drain does not mean that after your examinations that your brain is all drained out. No, it's not like that. That is, you got your engineers, doctors, architects, and moving on, that's a brain reskill, and that's what the brain human capital. And it leads to loss of trained people, science engineers, etc., from one country to the other. Oh, this is not working. It's not a video, it's not working. I'm surprised, okay? The video would have shown the cause and effect, but all the same, we try our best to do what we can here. We have got some push and pull factors for my push and pull. Push is what is pushing you from your country out. And then somebody there also trying to teach you, pull you, come. That's a push and a pull. These are all leading to. And my topic talking about would be how to deal with the push, because we are rather conceptually, that's how the public sector will train and retain people there. That's way to stop the push. And the push and pull, apart from that, there's the environmental factors, we have the geographical, economic, and then the professional. That's all those ones coming up in there. So these are the main ones in there. We have, as you can see, I've tried to give you some factors, some of the push factors. There are some political instability and conflict. Fortunately, Ghana, our political conflict is just to laugh. So you don't have that one here. Everything we try to make a joke out of it, so we are lucky. No political instability, as far as that's concerned, no. But other countries, conflict and the civil wars, and then the people mass, then they move. Because of that one, the people, their brains, just say, let's move. Then they move away. And then sometimes poor working conditions. He's highly trained, he wants to do this, and that. The equipment is not there, resources, the staff, they are not there. He feels he's wasting his brain, then he moves. And then sometimes they work a lot, workload. One doctor looking after about 10,000 people here and there. If you happen to be in a district hospital, you never sleep. It's too much. So let's poor working conditions, staff is not there, then they move. And then the other one, the cultural linguistic, sometimes because of the in place like East Pakistan, West Pakistan, India, for instance, they have similar cultures. If you take a look, some of them, they try to move from one place to the other because of cultural, etc., cultural ties in there. And some of the pull factors are, they tell you better conditions, there are better conditions there, higher salaries. Some of them, their salaries are about 6-10 times what they get in their home countries there. Why won't they go? The same thing there, especially if you train with somebody from a developed country, then he goes from you are here. You get about 10 times higher, so you have to higher salaries and then enticing you to come. And as right now, the demographics price is changing all over the countries. That you can even see in the papers or adverts, Canada and northern countries. Oh, Canada, easier to come in there. And they are giving scholarships here and the scholars all over. It's all wooing you. You get the scholarship there, you go and say, oh, when you finish, oh, Charlie, for this one, I'll give you some money to do some research. You do research, you do a master here, PhD, postdoctorate, then you are staying there. Taking all the brains in there. Professor Kuche's son is one of the leaders in the NASA, late Professor Gufongwe, his son, one of the Ghanaian. I think he was in Fansipion Wadisada. One of the leading experts in NASA is having there. They've taken him there, he's never came back, several of them in there. So they give you, when we were in secondary school, they give you, as part of attachment, that they screen the best. Now the green card and the blue card, they are coming in there. They look at the best. They take some referral, a lot of big ones, they're all taking them all out to fill in this one to get the brains in their country. At the present statistics, India has said that for every 1,000 people in Britain, there is an Indian doctor. Every 1,000 people, there's Indian doctor there. All over, national health. So taking all of them in there, that's how it's called the health conditions there. And then they give them other offers in some of the states in the US. As soon as you finish your medical training, do whatever, they come in there, will you set up a practice? Yes. Once you say yes, the next day, they hire a place for you, all the equipment is there. Then you see. Now you have to pay back. If you say you want to go the next day, the cost comes down by half. So you are forced to stay. And when we're saying the children coming in there, they go to school. By the time you realize you were about 65, the children, they are no more Ghanaians. You are there forever. You pity them. This is some of the ways that they try to entice people to go in there. So if you are trying to send your child, be careful. And then they have some very good policies, especially for the migrants. If you're a migrant, those who need them, Scandinavian countries, they need them bad. They give you this and that, this and you're a foreigner. This scale area, they put you in, they give you attractive. So why won't you go in here? Then the better quality, living standards. The living standards is very good. I mean, whilst coming here, a car broken down there, had no policeman, you had to go and turn around, all this one. These are all conditions there. You go back there, it's raining, it's leaking, no carpenter, no. So, everything is perfect. They make sure that why would you go? So they do in such a way that, so these are some of the pull factors. So the push factors, some of them, those of us from here, for instance, are personal safety. Safety, if there's uneasiness here and there, actually, I better go quietly. Better go. And then some people are so that they desire for further training to improve their skills, etc. That they desire to do some of them. And then also some limited opportunity for professionals. You finish medical school, dental school here right now. Sometimes these days they brought the postgraduate Ghana, but even it's limited. It's not everything done there. There are certain areas with limited opportunity. Not everybody wants to go in there, but still, they found out that this country is there. So it moves in there, gradually to moving to those sides in there. Some are academically inclined, etc. And then so some people are interested in quality, good life. That's what the good life, that's what they want in there. Like when you are in school, every evening you go clubbing. When the finish not there, come on, they just go in, not just clubbing. They just smoke. These are some of the push factors to let them go in there. And then the family, especially when the woman is abroad, outside, the man will follow. But when you put the woman in the rural area, the man won't follow. Rather, the woman will come from rural to the city. It's the opposite. Take a woman abroad, the man will follow like mad immediately. But you put a woman abroad, you come down, you won't go. So these are some of the push factors. Trying to do family matters is the push factors to let them go in there. The other pull factor has to be with the collaboration. That is, in the sense that they collaborate with the various countries here and there to sort of, to who the people are. That's what I'm talking about, who them out. And then they have a lot of educational opportunities. Everything you want to do, this and that, when you are there, you can still do it. So they make it easier for you to go in there. There's a scholarship you're sharing here and there. So trying to attract, to fill in. As I said, now there's the demographic pattern has changed. In China right now, they have more old people. I wanted to show you where they would have shown you. The balance is that there are more old people there. They are not dying. And then they are also not bringing forth. So they're trying to and China, Japan, is a little bit more of conservative trying to keep their, they don't want a lot of people to mix up, but it's happening now. All the people, they are not dying, and they also not bring forth. So they try to bring in wood factors so people come and balance the whole situation there. This really, and that's all the pull factors in there. They are doing that for most of the Southeastern countries. Okay. Now, migration. Every time we keep on migration, we should look at what are the effects. There are some negatives and some positives. Some of our diaspora colleagues, they look at only the positive aspect, but if you take a look in total, it's minimal. It's very minimal. For instance, if we have the negative, we have migration of skilled professionals. I understand in New York, one of these places, they have one of the hospitals. They have more Ghanaian doctors there than in Ghana here. All of them in there. They finish and they move in. Ghanaian doctors, they move in there. So immigrant skilled professionals, they go in there. And if you train it, how much do you train a doctor? You train a doctor for say about 200,000, whatever. I'll give an example. The recent Ministry of Health or Ghana government with Barbados. Whole nurses, they go in there, then they are paid, let's say, about $200. How much do you take and train the nurse? You don't get it. We'll come up to that one day. But the point is that we should sell the nurse, come and buy and take it away, rather than go and pay them. So we don't lose. The same thing. That's all the skills are going in there. And then we also, some of the negatives here, because of migration, we have limited economic opportunities. These are some negative effects of migration, limited economic opportunities. And then there are a lot of growing, a number of African migrants going up in there. And then the health sector impact. Many of the local born, there are a lot of local born Africans who are now, especially in the developed areas, who are migrants, local born Africans who are there. Then the positive, people say the positive, some positive benefits are, well, they give us money, remittances. But the remittance comes in there, they bring them to go and make funerals. You don't benefit. They go and pay about 4 story in my village. I mean, you can see that the total also, Ghana from remittance here and there, but it doesn't affect in any way. It doesn't put anything there. If you look critically, somebody going to sit up a hotel somewhere there, nobody is inside there, I go to a hotel there, funeral here and there. These are all the things. So the question about remittance that they talk about, it's neither here nor there. And it's, if you compare them to the number of doctors trained here and there, it's not all that significant. Then the other positive one is there's networking collaboration. Because of the diaspora people, they can mix connect because they are there. They can connect here and there. Business here, they can connect people, bring business here and there. That's advantage, of course. They know these people, their classmates, work, that's advantage that we can even. And then some of them, when they come out with skills, they come out with their skills if they prefer to stay in those countries. Taiwan, Hong Kong, Singapore, that's what they did. And they lured the people, they lured them in there. And that was Singapore with their skills in there. And some places, they come and set up the countries train more of vocational training. Vocational training, like if you're sewing, they bring machine training people so that the people come in there with their skills together. Otherwise, sometimes they come a skilled person, there's no supporting person. So if you make the environment very good, they come in there, disadvantage of that skill transfer, they bring all this one. Some have done other things which you can do. That's advantage. And then with their money, if they can come in, they invest. And that would put in there. Invest entrepreneurship, business, they got the business to do all those. So a little bit of benefit. But compared to the negatives, it's insignificant. That is the other one. Then the negative effects still there. The cost of training one physician cost of training one physician in the country is between 21,000 and 59,000. Globally, they're looking at it. The cost of training one. And then if you train one and then one, let's say on that, say about 30,000, it goes away. And every year, how much are you gaining? It's not the money itself. It's rather the people, the touch to get the people in there. I usually get a lot of my colleagues there. Oh, Kofi, my aunt, my mother is ill here. Can you get what you are saying? I say, bring your money. I teach them, bring your money to come and follow them, not human beings. You want you human beings. That's the problem. The money is coming there, but it's a human touch, which is really important. We don't get all those ones in there. Then there was a data where they found that 9 countries in Africa, 9 countries, the total that were about 2010, they lost about 2 billion in terms of the health workers that they got. Total cost, 2 billion from 2010. That's about 14 years now. Can you imagine? All that's going out there. And if you are able to quantify all this one here, we put a stop to whether we should train people or not. That's another side of it, whether we should train them or not. When we say stop training, those who are Americans will say, what do we do? So if they see continue training, then they will go. And then, for instance, it's something like, this is where, for instance, the cost of training, this one, and the destination countries, this is what they gain. If you in the UK, this is what they gain. That is 2.7 billion. That's the people we train, not a penny. They've taken them. If they are trained, they would have cost them 2.7 billion. If they had, if you take USA for that period, it would be about 846 million, and then Australia, that amount you can see all there. That's what they should have put in training. Now, they don't want, so you come in there, they give you scholarship, come in there, nurses, doctors, and we think it's very good. They are taking all the, instead of training them, they are not taking them free. They would have lost all those things. So these are the things. So how much they pay them? Just peanuts. But these are some of the, that's what they gain. Rather, they are gaining more. Some of the positives about the migration continues that the cultural exchange, of course, mixing up here and there. When there's cultural exchange here and there, we know understand people that you can collaborate here and there quietly between countries and the people like that. And then there's also one of the things that those outside there, because they have seen, quote unquote, what is good, they can force governments, please change your governance system, your, what do you call it, corruption here and there, this and that. You know, they have seen something. They can use that advantage to force governments to do it. For instance, I just read recently that, was it Nigeria or Uganda? He says some faceless people are sitting outside there and they are meeting people that you split the government out. That's what they are saying. That's my diagram. Then the other thing, diagram engagement. So because of the sort of aspect that they have, they can really come in and then sort of set up business here and there, locally, which they can take people here and this or that. Now, there's a brain drain going there, then there's a brain gain. The brain gain is the phenomenon where a country, the host country, you see, we are brain drain, they are gaining. They are brain gain, where the highly skilled people, they benefit from a highly skilled people, scientists, engineers, etc. So that's what it is. That's one of the things, that the brain gain, that's to them. But to us, it's a drain on us. It occurs when, for instance, they attract international students, especially international students, who stay after their graduation, as I mentioned earlier. They stay, you finish that. Now they've brought another, if you finish your PhD, come and say, do postdoc. They want to stay more. I'm just after a postdoc, they'll bring another post. They want to let you stay in there. PhD, postdoc. So you keep on working and staying there. These are attract international students. And they offer attractive money. This is everybody wants. Here, Ghana, everybody wants to do research. Because there's money there. The money for research, you do it. Simply once you are there, you are working for them, the economy is improving up there. And then they provide very good business environment, as I mentioned, the UF, for you to start entrepreneurial business in there. And once there was one time I was going to show where Mayo Clinic is, now the whole place is booming because people come there, the hospital there, therefore there's economy moving up in there. A lot of doctors are going there, other countries working, and other people are coming there, so economy also booms up. Just as around the Teshin there, because the hospital, there are a lot of people are building houses there to house people. They are not because of you. Building houses around there, people come in there. So economy booms. the same way in a country like that, they go in there, but here it's not, that's not the other way around. And it also occurs when those countries, they offer high quality life, high quality. You know, living is good. They do in such a way that, you know, they gain all those ones. They give very good policies for immigration. Sometimes when you go there, you see you are a highly qualified person, but very so quickly they take you on there. They like to come in there. And they force international collaboration between those ones. These are some of the gains that they bring in. And the positive benefits to the country, as you can see, is it enhances the economic growth, improve their healthcare, in terms of doctors, quality healthcare. I mean, if you can have, Indians can have every 1,000 people in Britain, it's an Indian doctor. I mean, they don't have even that their country. They don't even have that one there. You improve your healthcare, so get some more people there. Our nurses are going there all over. So they have one doctor, so many nurses. It's improving. Meanwhile, we are losing. They are gaining. And then motivation, they give capital for research. Go on, when you do research, you get a result, you improve your country. Then academic institutions there give you funds to go in the cultural diversity exchange. As you mentioned, these are some of the bringing that now, if you're in the States, you take one step, the Korean restaurant, take one the Chinese restaurant. Now there's a Ghanaian choba, somewhere they say Ghanaian choba proper. So all of the cultural diversity, all this one, you can be there, all the cultural places, they were Ghanaian Day, Singapore Day, everything. Culture, that's building up the whole place. So they are rather gaining. Then the other thing that they do is that some of the projects find is that they fill in the gaps. As I said, how the people age, they are dying. They need people to come in there, the skills. They are taking them in there. And then because of global network expertise, they can get them all over. And then there's also competitiveness on the global markets because of the brains that they have in there. Healthcare outcomes, and then reputation. Because if you have an example like Mayo, where Mayo is, this is a very good center for this particular thing there, a lot of people there. So they get all that reputation. Meanwhile, those countries who are different, they don't have anything just of that sort. Now, retention of health professionals to curb this thing. What needs to be done by the public sector? What do when you go back to and look at mainly the push factors, the push, it's where you should try to do something about the push. Not to push them. These are some of the things that the process, because the poor ones, you can't challenge them. The poor ones, you try your best, you can't do it. They're giving them 6 times the salary, whatever I did, they give you free this and that. So your push factor, what make your push them, I try, that's what the public sector should try and aim at. One is, some of the strategies are partnership with academic institutions. I mean the health workers, the public sector, partnership with academic institutions, so that they sit down, the curriculum, they develop the curriculum to suit the country. Most of the curriculum, they do not suit us. But if we partner with them, they will see what really like. We do prevent some of the develop what, for instance, there was a time I had a small friend when I was some years, but he's now qualified, he says he's a fellow. At one time I went with him, he was in the medical hostel. He said, Don Ahmed, how for this work, we won't do it. We shan't do it, we won't do it. When we finish, it's too much. What's that? They took us to a place, the place is boring, this and that, how can I do? He's a final year medical student, final year. So there's electricity. There's water there. What about house there? Where is that place? Ankafu. I cried to Ankafu, he says it's a boring place. He doesn't want to go. So is it because of the training that we give? That's what I'm talking about. Maybe if I don't know, maybe it's because we train, why is a final year medical student going to Ankafu of all places, he says the place is boring, how much more Tumu or some other place? So if we partner with the academic institutions, then we can collaborate and then develop the curriculum which will really sort of make us do some research to keep the people here. The other one is mentorship. I mean, there are some very good skilled doctors, health workers here. Why don't we send them, support them, put some people there so that they learn from them. They learn from them here and there. Because When we were in the medical, when we came out, we were all putting on bow tie because we had learned from Esrifi. Esrifi always bow tie, not you, I'm sorry. everybody was putting on bow tie. Mentorship. Once we're able to give pair experience, all this one, these are some of the things that we can use to sort of retrain some people in there. Then we do continue workshop education, workshops, training, conferences, take them in there. Take them to conferences, not something like as a benefit, to learn. Workshop, insight, etc. All this in there. Some people, when they do, they find out there's need to stay. They can really do all this, they can come in there. Then career development opportunities. We should provide, look at how best, we take a doctor you post him to outside the country. If you don't, you forget about the person. But if it's like armed forces, they say, when you are lieutenant, after so many, you go and do a course for captain. From there, it's scheduled there. Everybody there. But sometimes if you don't take care, you forget about you. Then you start making farm or rearing goats there. They say the man is happy there. It may not be, but he's taking time off these things. So if career development, etc., or do all those things, the promotion, not everybody can do, but there's a way. If you career development here and there, you can really do all those ones. These are some of the things that the public sector can look at and then see how we can retain the doctors in the country. Now, flexible work arrangements offer flexible scheduling, telemedicine options. So many things coming here and there. These new techniques coming there to balance life support here, and they can do all this one. Some countries have what we call student loan scheme. Here it's free. Students take how do you call it? Is this SNIT? Some of them run away. I mean, come and pay. You see, if I find some way of sometimes, if we can do some forgiveness or some them, these are some of the things we can really make them sort of say. We haven't come to a stage where people are giving scholarships for medicine, but at least government one you it's all the same thing there. So if we can find some means there, we can really sort of entice them to come and stay in there. People finish school here, there, and it's like the church mouse. How best can we do? Let them have some financial capital. We can sit down all these ones in there. And we've never sat down to ask, why are people living? We all know what is happening here in the village, but why are people living in Ghana here? We are living. We must look at all those ones, then we can find out some. Maybe the answer is a very simple thing. We don't know. Then community outreach engagement. I give example like medical student, but our doctors also. There was a time late. There was a time we arranged. We're going to have outreach activity with the private practitioners all over. All of them. We spent about the whole week. We met the private practitioners all over. We met in Korle Bu. We planned here and there, how we go about this, how we go about all these ones in there. We planned everything there. And then we provided, everybody chose where they want to, which region, or all the day, like here. The one the day came, we provided vehicles. Everybody gave an excuse why they can't go. Everybody gave community out. Everybody gave an excuse why they can't go. So these are some of the things, community outreach, if we're able to engage all these ones there to train them, we can really retain some people inside the country. Now, this one is compensation. Compensation, how to compensate people for the work they do. It's really the point I tell people, this one I'll say it here again. People think that we have got police service, prison service, education service. There's no Ghana health. There's no health service for Ghana. Anybody switch? There's no health service for Ghana. Because if you look at the police, they've got one police council, which puts everything there. Prisons, all that one. Health, we don't have. We have what we call Ghana Health Service, Korle Bu, Tamale. They are all different. The chief executive of Tamale, Cape Coast, they are all the same as DG. That's our policy. Health service, if you look at Ghana Health Service and Teaching Hospitals Law, we don't have one. So there's no way we can make one policy. Bank of Ghana, they are counting money. They build the hospital. They are only counting money. They build the hospital. GRA, they are taking, somebody from GRA, I won't say bribe, they have taken money from, they build the hospital. Why can't the health establish its own hospital? Because you are in the hospital? No. You must build your own hospital for your workers, so that when you retire, you are not working. You can go in there. There's no big policy for national service, national health, to come out with a policy like that. Universities have got, they got their hospitals. When they retire, they go there. Why can't health have its own hospital, so that when they retire, people can go? These are some of the things that you have to look at critically to see, so that at least if your pension is not small, it's nothing, when you go to hospital, you won't pay consultation fee. These are things that you have to be looking at. Private sector can even look, the public sector can look at. Then leadership in different programs. Try to ensure that the doctor, we put them, not only because he's in tier doctor alone, try and make sure that they are, late Dr. Grant said when he was in Pandu as a medical, he was at that time, the medical doctor was the second highest civil servant in every district. So there were sometimes Empire Day, he would go and take salute when the DC is not there. Why can't we do it so that graduate leadership, leadership in Ghana, so that, I can't say, but leadership, so that this community will accept them as being leaders. It's our own way. Another thing is, we don't have any code for our doctors in the country. I'm sorry to say this. For instance, if you take a look at lawyers, they say if somebody is a senior man, he goes to court, there's a junior man, you sit down, you come and present the case and go. Here, doctors, whether you're junior or don't care about you. I'm giving examples. You must put some discipline in our system here. These are some of the things we can really, some of them get frustrated. Look at how there are some cases where some of our senior doctors, some of our teachers who have retired, and they're suffering in Korle Bu. Suffering, I can cite so many of them. You see, all this, why wouldn't I go? So that when I retire, so these are things one has to be looking at. Then this last one here, private partners collaboration. Private partners collaboration. This is exactly where you come in here right now. Dr. Nyahu, Dr. Nyahu, when I was in Korle Bu epidemiology, I would tell him that, Dr. Nyahu, you see, if you bring me your returns, I give you vaccine. He was the one, he became a vaccine carrier. As soon as Koko Kofi, here are returns. Then we start to talk. As collaboration, give me vaccine returns, they take this one in there. There was a time when the health workers were saying, when you're doing mass camp, he said, no, don't give it to don't give vaccines to the private clinics. Don't give it to them. Why? They are charging. I said, if they are charging, are they charging Nigerian children? The parents of Ghanaian children, they are charging. So if you refuse them, you are refusing the Ghanaian child. After all, if you may go and spend 1 hour at Malata Market to get vaccinated. Somebody spent 5 minutes at so much clinic. Time is money, you don't know. He's prepared to pay. So these are some of the things that, that's why a lot of the vaccines that come from private, people were anti. So coming there, so we just hoping that it should be both sides. There should be the private sector also, should have avenues whereby they can also make this coming. There's a talk going on with the last one, going on there, which I did. You know about CHAG? CHAG until recently went to Tadibo. It was went to Tadibo, I can't get the date. That we signed a Ministry of Health. You don't know Ministry of Health paying all CHAG health workers. I don't know whether you know. All the CHAG personnel, they are getting salary from the contract under the Ministry of Health, but they are separate. Except that auditors go there, they check the money, they take the money here and there. I mean, look at the personnel there. We have talked about this. In fact, I'm surprised I was asked to come and talk. We were talking about this with some very high personnel about this one. Why can't we send some of our doctors or health workers to the private clinics, private physicians? So when I was so happy, I said, we are discussing this. You're saying that there is nothing like, after all, they are attending to Ghanaians. And when you talk about ratio, 1 doctor to this, it's the same thing. So if CHAG is a society, it was a society on its own, under the CHAG, they didn't want to. Now we group them all together. We send doctors there, we pay them. They give them allowances, everything. It doesn't care as far as they are there, but at least report on them, they are giving service. If the society can come out strong enough and work out, we can work it out. We post the doctor or nurse to SP, Society of Private Medical. We post him there. That's why you are sent there. You get your society, you work there. So we were talking about this not long ago. I was surprised. So these are some of the things we've been thinking about to see how best they can improve. These doctors are trained. Post them there. I was working at Kusumbu. I was getting my salary from Control Account General, just like any other doctor. But when I was there, at Kusumbu, free accommodation, free electricity, free water, free bus, free something we pay for. So anyway, I won't mention. Everything was free. So at least I was taking my salary. But when you see me, I'm just like Kusumbu. They are higher than mine, but because of those ones in the I think I was better than somebody who wasn't there. So these are some of the things that you should also think about, that we can really work about and see how best we can get some of these sort of workers coming. The last one I would just like to end on is about the sort of, to see to the training of the medical students. If you can work out something so that some of them can come in there a little bit during their time to come and spend some sort of, I won't say rotation, some time there. If that's what it does, so that they know what they are coming to there, they can come in there. But these are some of the things that when we do these ones, we can really sort of keep this in this. And I think I'd like to thank you. Sorry I couldn't show you the videos, but I thank you very much for giving me an opportunity to talk about it.
Right. I think if you look at it critically, we have the push and pull factor from Dr. Kofi Ahmed. And I think during question time, we'll remember and do all those things. He also talked about public-private partnership. But I can assure you, the public is rather drawing things from us when something is due the private person. So we should look at that one too and discuss. Now let's have another promotional presentation from Tobinko before we go on to another lecture. Tobinko, if you're around. MDS. Okay, so we have MDS Lancet to present.
Good afternoon, senior colleagues. My name is Dr. Edikem Kumaho. I'm a medical doctor, and I have specialist training in laboratory medicine, chemical pathology. I have been mandated by Dr. Paul Setrenantechi, CEO of MDS Lancet, to come and introduce to you some new biomedical tests we have validated in Ghana to support cardiovascular disease diagnosis and management. So the outline for this presentation, I'll briefly go through shortly the basic biochemistry of lipid testing, and then we'll talk about what we've introduced now, where we are directly measuring LDL cholesterol, and then we'll go ahead talk about some advanced tests in measuring apolipoprotein A and apolipoprotein B for diagnosis of atherosclerosis. And then I'll do a short presentation on the new tests we validated in Ghana and the times we can get your results available to you. So, the current state of lipid testing in Ghana. Currently in Ghana, when you request a lipid profile, usually a fasting lipid profile, we would report the total cholesterol, the HDL cholesterol, LDL cholesterol, and triglycerides. From the slides, you would note that the LDL cholesterol is calculated. Now the question is, why has fasting been the standard for LDL cholesterol measurement? The reason is basically because we use a formula to calculate the LDL cholesterol we call the Friedewald formula. And this formula assumes that the patient should be fasted for 8 to 10 hours to ensure accurate LDL cholesterol measurement. So the main reason why lipid testing has been fasting throughout the period is because of this formula we use to estimate LDL. But there are other ways to estimate LDL cholesterol. So over the past decades, several regional organizations, Europeans and Americans, have shifted to non-fasting lipid measurements. And it all started in Denmark in the year 2009, where there was a policy that routine lipid fasting should be non-fasting. Routine lipid measurement should be non-fasting. And as of 2017, almost all the countries or almost all the regional authorities have also moved to recommend non-fasting lipids as the benchmark or the first line for lipid testing. The benefits of running non-fasting lipids is very practical. It's safe for patients who are diabetic, elderly patients, pregnant women, and children. It also increases compliance to laboratory testing since your patient doesn't have to go and come to run the test. It saves costs and improves laboratory efficiency. It also makes the hospital or the clinic look very good because the patient turnaround time is reduced. So currently, we've introduced direct LDL measurement to circumvent the challenge or the limitation that the Friedewald equation made, requiring all patients to fast before they get accurate LDL cholesterol results. However, we know that not every patient can have accurate results on a non-fasting lipid test. So in a few conditions, especially patients who have these genetic or primary hyperlipidemias, it's still recommended that they would do a fasting lipid test. And of course, if your patient is running a fasting blood glucose or plasma glucose test, then it's okay to also couple in your fasting lipid tests. Now, for our non-fasting lipid test, which is the direct LDL cholesterol measurement, we can get results ready to our clinicians with a 4-hour turnaround time. Meaning when we receive the sample, within 4 hours, you get the results emailed or printed for your patients. We take this a step further by talking about the measurement of apolipoprotein A and B in Ghana. Now, we know that the main particle or the main agent in lipid metabolism is not actually the cholesterol in the lipoprotein, but the lipoprotein itself. So the lipoprotein, so we realized that traditional lipid profile measurement gives us an incomplete picture of what is actually going on in the patient's blood, because we know that for some patients, they may have normal cholesterol levels, but still have a high atherosclerotic risk, or they may still have a high cardiovascular risk. They may still be very prone to atherosclerosis. And this is because they may have high lipoprotein particle density. For example, they may have very high concentrations or levels of the low density lipoprotein, which mainly causes atherosclerosis. So we tend to estimate the number of lipoprotein particles or LDL particles by actually measuring the apolipoproteins present on the particles. And this introduces the use of apolipoprotein A and apolipoprotein B in the measurement or in the estimation of cardiovascular risk. We know that various organizations have now incorporated these into their protocols for diagnosing and managing increased cardiovascular risk. So the recommendation is this. For patients who are younger, maybe on the obese spectrum, and tend to have increased cardiovascular risk, like having metabolic syndrome, it is preferred to measure the ApoB, which actually gives you the density of LDL particles in their circulation, compared to measuring the LDL cholesterol, which may be normal, but these patients will still have increased risk of strokes and MIs. So we have the ApoA and ApoB. ApoB measures LDL particle density. ApoA measures HDL particle density. And we are seeing that it is becoming more recommended by some guidelines to diagnosing patients at high risk of atherosclerosis. And the turnaround time for these tests is also 4 hours. Now, we've known in the past that there are some of our tests that take about 2 weeks to get results, especially these specialized biochemical tests. But the good news is that we have been able to validate these tests in Ghana now, and we are offering shorter turnaround time. So I just want to give you an update on that. So for our autoimmune panel, we have, for the diagnosis of rheumatoid arthritis, we currently offer quantitative rheumatoid factor. Rheumatoid factor has always been qualitative. It's either positive or negative. But now for patients, we are able to offer a quantitative IgG concentration so that the patients can be monitored on therapy. We've also introduced anti-CCP for the diagnosis of rheumatoid arthritis. And the turnaround time is 3 days. For our patients who are suspected to have SLE, we currently have in-house ANA and the ENA panel, and we are offering that at a turnaround time of 72 hours or 3 days. But if the laboratory is notified, results can be given to you in 24 hours. For advanced serological testing, we have the TORCH panel for our pediatric and neonatal patients, and that has also reduced from 14 days to 3 days turnaround time. For emergency cases, 24 hours. We also quantify the H. pylori antibodies, and the turnaround time is 3 hours. For therapeutic drug monitoring, currently in Ghana, we are measuring tacrolimus for our renal transplant cases, those who have been put on tacrolimus for autoimmune disease and steroid-resistant nephrotic syndrome. And the turnaround time is 2 days. But currently, for the renal transplant project in Kolebu, the turnaround time is 4 hours. We're also measuring lithium for patients who have mood depressive disorders.
Right. I think we should ahead. All that we have now is from the MDS laboratory, but I wonder how many of us have been doing some of these tests for ourselves. So if you haven't been doing it, this is the opportunity to start doing it. If your friend hasn't been doing it, it's a time to advise for all this, because we don't just get this sense without practicing it on ourselves. Colleagues, we come to another very important topic, and that to be presented by one of our own. He's a Deputy National Secretary, and basically he's a public health scientist. He's worked with a lot of organizations, particularly working with institutions in a lot of African countries, Europe, and North America. He's adjunct lecturer in the KNUST, and also so much interested in infectious diseases in Africa. So he is therefore an infectious disease consultant. And I'm sure he's coming to give a lot of things for us to know. And he's also with the Ghana Canada Medical Center. His topic is key and vulnerable populations health needs in the private sector. So we call on Dr. Henry Nagai to give this presentation.
Thank you very much, Prof, for those nice words. I had to jump into this area because the third speaker could not attend, and so we need to redeem the time. But I'm going to, the topic is one of the special topics that the scientific committee put together. So it's not directly connected to the brain drain as it were, and so we look at this particular area. And I thought that I would be able to do it as the last topic on the last day as a take-home. This is because there are certain areas of this conversation that is going to be new to you, and it's going to be challenging to you. And so I thought that if there will be further conversations, we can have it when we have closed, maybe tomorrow. And so the topic was supposed to be the next day. So pardon us for in the private sector, and I haven't been able to join the sector not too long, and I'm very proud to be part of the society and the executive committee. I've realized that there's been a gap in this area, in our knowledge and how we look at what we call key populations in the health sector. So I'm going to draw our minds to some aspects of it and take us a little bit about, take us into some of the areas that are critical, so that as we sit as private medical practitioners behind our desks and we see people from different segments of the society, we are conscious of their needs and we'll be able to meet their needs. These days, it is patient-centered care. It's not like when we sit and we give directives and it's physician-led, so we are just giving people orders. It's more to do with ensuring that we can provide care that meets the needs of that particular patient. The definition for quality health has changed a little bit to be patient-centered care. So we need to know who is coming and is sitting in front of us to enable us to provide the best of care, even in the private sector. So I'll take us through who key populations are, and as I said, there may be certain things that are new to you or may challenge your minds, and we need to discuss those. When we say key populations in public health and in the sector where we work, whether in Ghana or elsewhere, we are referring to a group of people who, due to some specific risk behaviors, have increased risk of HIV, irrespective of the type of the epidemic. Sometimes you hear this, it's called generalized epidemic because the level of the prevalence in the country is more than 7%. If it's less than that, then there are other definitions who say that it is localized. In Ghana, HIV prevalence is described as generalized. There are certain regions that have high prevalence, and there are certain groups of people that have high prevalence. But in general, the general situation is such that it's considered as a generalized epidemic because it is just about 1.2, 1.3%. But I'll go into some. So when we talk of key populations, remember that we are referring to a group that, because of some risk behaviors, are categorized that way. And they have legal and social issues related to their behaviors. So there have been a lot of noise recently on one particular group. I know many of us will sit on different sides of that argument, and that's why I said it's something that we need to be aware of as practitioners in the private sector, because we see different groups of people and we need to know about it so that we provide care that meets their needs. These are very important, especially for the purposes of us as practitioners, important in the dynamics of HIV and sexually transmitted infections. And importantly, they are critical in formulating the policies, in formulating some of the clinical protocols that we need to use to meet their needs. And so in many of the policies that are coming out, clinical practitioners' policies within the public sector and within different large-scale involve members of these key populations so that we'll be able to know their needs and meet their needs. So look at the last point there is very critical for us practitioners to know. There are some terms that as scientists or practitioners we should be aware of. And as you read documents on these, or we hear them around, and maybe we get people who come to see us and they use some of these terms, we should be aware of what is being said. And also, as programs in the country from the Ministry of Health is making effort to help to reduce infection and transmission in these populations, we should be aware of them. So you hear terms like hotspots, or street, or red light districts. For a group of key population, that we refer to as roamers. And in our public health practice, they come and they are consulted. They want to do sit for maybe hours, or they may inadvertently meet somebody who might know them. They want to engage with a private practitioner. And we need to be conscious of it and be able to meet their needs, irrespective of Oxford Street, where they have a lot of 26% in MSMs, men who have sex with men. Okay, and there are reasons for this. I'll indicate some of them. Penile sex, it has about 6 times transmission probability, if you are MSM, of a CEO of a very large multinational company. Okay. So just for us to know that we have high prevalence in these groups, and I mentioned these transmission probabilities for us to understand. I mean, having sex with someone with HIV without condom, and I'll talk about what protections are there so that we are aware, antiretroviral therapy, or pre-exposure prophylaxis called PrEP for HIV. The risk is higher, being about. So they have those that are bottom and those that are receptive, and if you read it, you understand that being receptive partner is 6 times more. If you read it, you understand that being receptive partner is 6 times more in terms of transmission probability, penovaginal intercourse, and so all the intercourse, and so all these factors contribute to the level of HIV prevalence. You own this group and make sure that whoever wants to do whatever he's doing, or is a client of a female sex worker, is safe and will not pass on the infection. Basically, safe and will not pass on the infection. Basically, there's a lot of stigma. there's a lot of stigma and discrimination, and that is why we also need to understand and know the needs so that we'll be able to serve this population better and support the government in reducing infections. There are reproductive health issues reducing infections. There are reproductive health issues, and I've mentioned some of the prevalence in terms of STIs. There is what we call combination prevention, which I think we should all know, so that we'll be able to, wherever we sit and we see someone that we think, could the person be coming from one of these populations, we can be able to help. We have the biomedical, behavioral, and the structural things that can be done. So, condoms and lubricants. Condoms and lubricants. Please, as private practitioners, I know we always want to do our clinical work and just finish the prescription and just get on with the next patient. But let's not forget the use and the importance of condoms and lubricants. These are very, very important tools for prevention of infection and to saving the spouse or the partner of that particular individual. There's HIV testing services, and one of the things that we should know as a take-home from here, which I'm sure many of us are aware, is the availability of HIV self-test. That we can support anybody who wants to know the status to pick a self-test. And whilst he sets the test up, you can do it at your home and you have a bottle of beer or a glass of wine for 20 minutes and you will know whether you are HIV positive or not. If we think that individual have a high risk, we should be able to make sure that they know that there's HIV self-test. Then we all know the prevention of mother-to-child transmission. Obstetricians here are aware of that. It's one of the most single important interventions because when the child comes down with HIV infection, it's for the rest of their life. And in fact, it shouldn't be the case at all. No child at this point in time should be coming down with it because we have drugs that prevent the transmission. And that is why now we say opt-out approach. When they come to the facility, everybody is offered the test. It's like part of the panel of tests that we request for our pregnant women, unless they say no. These days, we say test and counsel, not counseling and testing, because we know there's treatment available. There's no cure, but there's treatment available. Oral pre-exposure prophylaxis, PrEP. When you hear the word PrEP, it's pre-exposure prophylaxis for HIV. What it means, we now have drugs available. I happen to have been part of the team. We did a feasibility acceptability study. We now have the drugs available. We have tenofovir and emtricitabine combination, or tenofovir and lamivudine combination that we give as pre-exposure prophylaxis, especially for female sex workers. Then here is where, as private practitioners, it may come to us. Because just about 3 weeks ago, I got a call, and I'll explain to you what happened. Post-exposure prophylaxis. Post-exposure prophylaxis is that you take the medicine after the act to make sure that you don't have establishment of HIV infection. And this is very, very important. It's important, especially when you look at PEP, you see IPEP. That is the post-exposure prophylaxis that we give to the children. If Dr. Sowa, my uncle, happened to operate on a child and the mother is HIV positive, and the medication with the zidovizine syrup or the cocktail we give is to prevent the child, if he has been exposed in the canal to the HIV, to make sure that the baby doesn't get established HIV infection. So we have IPEP, infant post-exposure prophylaxis. Then we also have OPEP. This is very important. in our workplaces as private practitioners, as we have our facilities and we work, these days, about 60% of the work I do now is telemedicine and online. I don't have a lot of time. So I'm a bit safe from the, but we have occupational exposures. Please ensure that that staff can get post-exposure prophylaxis, occupational, that is related to the work. Maybe you get an injury or operating, you have a problem. Set up that system to make sure that the medication is available, is a combination treatment, 1 tablet a day for 1 month to make sure that that staff doesn't come up with an established infection. Then we have non-occupational post-exposure prophylaxis. That's where a lot of people were. 3 weeks ago, what I'm talking about is a non-PEP. The man came down to Ghana. He had a friend with one of the ministries. They went and had a fling, and later on found out that the lady is HIV positive. So I'm sure somebody called them that I should call me. That is non-occupational post-exposure prophylaxis. So I have to give him medicine to make sure that he doesn't seroconvert, to make sure that he doesn't get HIV transmission that will establish becoming infection. So the medications are available for IPEP, for OPEP, for NPEP, post-exposure prophylaxis. And some of the private, a lot of people like to have this. And that's not the only one. I've had several calls from different people on this. VMC, we don't see it a lot in West Africa because about 90% or more of people are circumcised. Then for our people who inject drugs or people who use drugs, we have the needle and syringe programs, etc. I don't want to go into that. But these are some of the behavioral prevention methods. I've spoken about this. My last point here is where I have a problem, which I think that as practitioners in society, we must take it up. I'm talking about social marketing. We have a practice model that makes us all here not to talk about what technologies are there, what specialists are there, what we are capable of doing, and what is available to save people. It's because of the model of training that we've had and the regulatory regimes that we've inherited from the Anglo-Saxon approach. And it's not bad. But social, which the society, I'm happy to say that we're trying to look at that, and you will see it coming through, is to tell everybody what St. Alban Clinic has and can do, and what specialists are available and what can be done, and make sure that they are aware through social media and everywhere. Because some people sit with problems. They don't know that there's something called non-occupational PEP. They have a fling and they get down with HIV. Meanwhile, drugs are available. Or if the person is a female sex worker, he doesn't know that there is exposure prophylaxis. The medication is there, doesn't know about it. So social marketing is making known the technologies. It's marketing, but for social good. Not for the commercial thing that we see these herbalists do. So we need to be very careful about how we are hiding typical scientific information for people because of our...
Professor Albert Apalu. And again, Dr. Nagai, I think it's also come up stage. DS representation and MDS Lancet. Okay. What are our presenters? The DS Lancet. Yes. Oh, okay. Great. So the floor is open. questions are, you should be brief and straight to the point. First question, yes. First question, yes. To anybody. Oh. Okay, I think you can stand and ask. Otherwise, we'll be moving around. But I think because of you being the former president, you can come and talk over here.
Thank you very much. My question is to Dr. Nagai, whose friend will be dodging me left and right. Dr. Nagai, we are happy that you'll be able to delve into the positive aspect of this sector and disease. But my observation and direct question to you, as regard in marriages, I know when HIV became very hectic. You go to churches, couples want to marry, you ask them, go and do a test on the HIV. Sitting on their human rights, to what extent do you have experience through your research work, which you can help your colleagues and all of that? Whether you agree or not. I'm looking at from the point of view of human rights.
Occupies. So he came to me and requested for circumcision. Looking at him, you know, somebody about between 60 and 70. Why? He told me that, look, there's a stool in my place and I don't. So this is the only reason I can use to avoid it. Do it for me. Circumcise me, and I will have a justification to avoid the taking the stool. So it exists. That's what I wanted to say about that one. And the other thing I wanted to ask is about, I have a relative who domicile outside. Sorry, I've been a bit taking too much time, but
I think some of those ones we can discuss over cocktail.
okay. The last one. It's this gentleman. It's a relative actually, with a wife staying outside, and when they reached there, both of them decided that the lady should go into sex trade or what. Yeah. And through that, the woman developed some serious complications due to some infections. Later, they sat down again, and in fact, some more or less curse put on both of them that the man should swear that he will never leave the lady because he convinced her to go into the trade. Have you had any situation like that before? Thank you.
Right, we'll answer let's answer the first three and then we continue. Right.
To do your first or last. Okay. So thank you. He's a very senior.
It's totally different. I just want to speak to the question about religious houses mandating and doing things. In Nigeria, there's an anti-HIV discrimination law. It is illegal for anybody to have your HIV result before you. It is also illegal for anybody to discriminate against anybody on account of their HIV status. Yes, the law is there, but we still have this happening. So I think one of the things that can happen, because beyond HIV is no longer a death sentence. Like I met Linda, but you to go to you is real. So start to take your medicine 6 months after, you cannot transmit it to any other person. And that's why some people say they've been cured. If you do your HIV test, you will come out negative, and then you can go and testify and say the man of God laid hands on you. But you still, if you stop using your medicine, you will. But if you use your medicine, you'll be fine for life. You'll be okay for life. So the gender and human rights component is wrong, is illegal for us to discriminate against anybody because of their status. They should live a free and happy life. Thank you so much for the work you are doing, sir.
Right, yeah. Please have it.
I'm Daniel Kwe from. I am very worried about this notion that we should encourage, partners with HIV. I mean, one partner with HIV positive and the other one negative to marry because the other partner is on treatment. My fear is that with this kind of swinging economy, how are we sure that these HIV drugs will come all the time? And shall we be held responsible for not disclosing the true identity of a partner to a potential spouse or to a potential spouse? In case things get bad, the economy gets bad, and then the drugs don't flow in to prevent the HIV infection. That's a great worry to me.
Great. Let's have another question. Okay.
I'm Emmanuel Diaba, also from Tama, Port Medical Center. My worry is about the social engagement Dr. Nagai suggested. My worry is that if you go out telling them now that there is pre-exposure prophylaxis, would the society not lash back at us? That means we are encouraging prostitution in.
Okay, I'll give one to.
So, thank you very much for the questions. I just wanted to find out from Dr. Nagai, has the law changed about disclosure? So, because we run a multi-specialist clinic, I have a spouse of a patient who I diagnosed as retroviral positive. Husband was negative. She insisted on doing it several times. The husband was negative. So, the husband has a genitourinary problem. So, we have a catheter in and has vowed that catheter should stay in till she's ready. So this is about 5 years now. So what is the law on disclosure now?
Thank you very much. That's the reason why we are here. Because as you said, we realize the private medical groups in countries do not have these updates, unlike the public sector. But we are critical providers in the space. And so I'm happy that we are having these questions. Before I come to disclosure, we are not saying we are encouraging those who are serodiscordant to marry or not to marry. This is a scientific fact. And so to tell someone based on religion or your own values that because somebody is positive so cannot marry is wrong. Because treatment is available. And in fact, the examples are too many. So we want to make sure that the individual who is positive is able to receive treatment and therefore can get married. In fact, it's all over. They've had kids. So that is settled now. That when someone is positive does not mean the person cannot marry or cannot have unprotected sexual intercourse and make babies. That is settled. So we are not encouraging, but when they are serodiscordant, one is positive, one is negative, disclosure. So a lot of the challenges we've had, in fact, there are a lot of fertility clinics that I do work for. This comes out a lot. So when you are faced with a disclosure situation, it is important that you can bring in some specialists. There are methodologies of supporting the partner to do disclosure. The partner can be taught how to do the disclosure. The partner can be supported to come together for the disclosure to be done. In fact, in St. Martin's Hospital, when it was not done well, the man almost did something to us in the consulting room. Okay? So we have improved approaches, and they are trained on it to be able to do that. The other thing is that, so I've had clients who for 20 years now have not disclosed. But they are on medication and they are okay because U is equals to U. You cannot, by the law, because of the confidentiality clauses that are there, a physician cannot disclose information that is privileged about a client to another party without authorization. There is shared confidentiality in facilities, hospitals where we work, where we know that this is what is going on. But if you want to support disclosure, there are approaches. The individual needs to be supported to have practical approach for doing that disclosure, as you're going to have a problem. But the good news is that because treatment is available, a lot of people who disclose their spouses are helping them to rather be on the medications. Because when a client comes to you in the private sector, sitting in front of you, maybe a client who is living with HIV, who is living with glaucoma, who is living with hypertension, who is living with diabetes. HIV has moved from being what we know previously to a chronic disease because treatment is available. Then there's an issue about pre-exposure prophylaxis. And as I said, I PEP to the child, and then I referred to the prophylaxis that prevents the transmission. What we have found in our studies is that it doesn't create this inhibition. That because pre-exposure prophylaxis is available, so we'll do what we want to do. We found out that it's like when we studied HIV self-testing. People say, hey, if they get the self-test and they are positive, they'll go and kill themselves. We found out it's not true. People get pregnant, they do their personal pregnancy test. When it's positive, they decide to do and see physicians, etc. There was a question I was asked when coming here. Let me address it before. That are these available in the private sector? Yes and no. Yes, because some time ago, I happened to have led a team, the World Bank program, which supported a number of private health facilities, Bomso Clinic, Port Clinic. Dr. Ayer is here. He was involved in that program. Many of the facilities, they are private self-financing health facilities. And we push to bring them onto the program to benefit in training and infrastructure and everything. That's one of the things the society is trying to, and I'm sure the President will speak about this tomorrow. Because we provide services, and so we must benefit from the pipeline of resources that can help the private sector to provide some of these services of public health importance. That is not charging commercial fees. So yes, it is available in the private sector, but not everywhere. And when we finish with the directory that the society will be launching, hopefully next, I'm preempting certain things. We will see that we can have a referral directory that all of us can benefit from because clients will know what is where and who they can talk to. So yes, it is available in some of the private health facilities. In fact, Port Clinic is one of them. Bozo Clinic is one of them. Dr. Nyan's Clinic was. I mean, I'm just, a lot of them. Holy Trinity, Odona Clinic. They are available. They are in the private sector. And I'm sure it might be planned for us to make this more, and involve more private self-financing providers.
So I just wanted to ask a little controversial question. I used to serve on the Ghana AIDS Commission. Now, currently funding is not available because most of our programs are not aligned with MSMs and FSWs. Now, condoms, we said about condoms. If you go on the market, just for curiosity, cost of a good condom is more than a bottle of beer. So why should they? So it's not the cheaper condoms that were available by the Ghana Social Marketing Foundation are not available. So it is a big problem for us. So we are not giving cheap available things for prevention. So the other thing about the disclosure is it's sometimes very difficult. I had a very good friend of mine was the third wife of somebody who we knew was MSM. So what do we do to her? So I said, okay, She said, no, she wants to. I said, okay, the only thing I can tell you is that you use a condom. That's all. So her usage of condoms saved the first wife passed, the second wife passed, but she was saved. So I knew at that time I didn't break the law, but I just told her to wear the condom. In the opposite vein, when I was doing obstetrics and gynae, we had an allergy with first wife came 3 children, second wife 3 children, but third wife no children. Allergy azoospermia. So we just told third wife, go and see wife 1 and 2, and they'll give you the secret. She came back, also had her 3 children. So that's the opposite of disclosure.
Yes, I must disclose that I work as the, they call it the chief of party of the large-scale PEPFAR program in the country. The issue about funding, when you hear funding for these things, is in 2 ways. There's one part where we have resources, we are not able to have a good burn rate. So the money is taken away. And then we have other things that we want to do that the money is not earmarked for. So the issue of condoms is that the condom spectrum have different prices and different types, and to meet the pockets of different people. Prof. Albert, I'll recommend Ebony, which is nice and very packaged, and there's a strawberry part, and there's a vanilla, and others. And maybe someone, I mean, I'll say, can you go in for, we call it no logo. It doesn't have any logo. It's just, and it's like maybe for free or for some 1 or 2 CDs or 5 CDs, or, you know. So there's a spectrum of that, but what you are saying, I get it. Because what you are saying, we should make condoms that are cheaper and more available. But condoms are available, and we must find ways of making sure that it's not only in pharmacies, tabletops and places where somebody go and when he sees another person, instead of buying condoms, he says, I'll buy paracetamol. Or, you know, we have several of these. People should move boldly and have a condom. It is either Ebony or it's any of the nicely packaged condoms. So that's what I can say. So we need to have more of that. But disclosure is important. There are different methodologies. They work. We've had several people who have disclosed. And the man, if he gets to understand that if he's taking treatment and he takes his medications from 6 months, for 3 months and going forward, and it becomes negative, that is a big push for him to be able to work on a way for the disclosure. We've had clients who are currently living with HIV. They are on their treatment for years. They've given birth to children. They've not disclosed. Some of them have actually gone through the process and disclosed, and life is fine. Really.
Good. Yeah?
Any more questions?
I will add that you might be reading some literature. We have the injectables, what we call long-acting injectables. The cabotegravir injectable. The person gets a jab, and for every 3 months. Now it's becoming every 6 months for pre-exposure prophylaxis. And there's one recent one, the lenacapavir, which is once a year. Yes. It will become very soon available. Thank you.
Thank you. It's becoming more interesting. But, well, let's show our appreciation to the presenters. However, for those of you who were not around when we started, we'll give 5 minutes to each presenter to summarize what they've discussed. So,
thank you very much, and thank you for the attendance. I spoke earlier about medical tourism in Ghana in the private sector, and I said it was a low-hanging fruit, and there are lots of opportunities for us to get access to international patients, but it comes with quality standards, comes with accreditation, and it comes with the marketing ourselves and our facilities that we had. And we also spoke about collaboration. So instead of trying to do everything, we have centers of excellence and we have that good referral system, and then we can zone each place and make sure that we have centers of excellence where these referrals can go through. So I talked about the JCI accreditation, which is the gold standard, but we can work towards that by improving our quality and improving our standards. And there's low-hanging fruit there. People cannot get appointments abroad. We have the well-to-do and we have the personnel and the know-how here. So let us pick these low-hanging fruits and improve our medical tourism. And I gave case studies of the various institutions that we have, which are internationally accredited and can match any place, anywhere in the world. Thank you very much.
Thank you.
Brain drain, and then the main thing is about how the public sector can stem the drift, that is to train and then retain the doctors, to train the health workers. And I think it's two sides of this question. The private sector should also be ready to collaborate with the government. For instance, I can give an example about the CHAG. When they started getting the staff from the ministry where they are being paid, there was a time that when the auditors go there to inspect them, they say no, they have to seek permission from the bishop. The bishop first. They said no, it's not the bishop matter. They are rather coming to look at the money they gave you, how you have used them. That mainly for the monuments here and there. And I'm saying these are some of the things that some of the private, when it comes in there, you have to be careful that there may be some maybe infringement to privacy here and there, but it's one way that I would rather support that one. That, for instance, we try and send the doctors more to the private clinics. If they can only contain them, but they are not going to pay. The government is going to pay them. Rather, they will give them some incentive for them to stay on. So this is one way that they can really do to sort of stem the people. Some of them go out because they have nothing to do, so to speak. Example, like I gave an example about the nursing one. So many nurses being sent to Barbados, Caribbean. But yesterday, Ghana was going to employ so many doctors. When you look at it, if you can sense that, why do you keep on employing here and there? I mean, these are some of the things one has to look at. The other thing about it is about the training. There are some arguments about why not stop training people. If you are training them and then you are not selling them, you are not selling them at the market price, they go. You say, remittance, you are losing. Why don't you? So it's a contention issue, that one, to stop training more of these health workers locally rather than to train the few that we need. Or we train them and see how best we can sell them. Somebody was saying on one of our groups here and that footballers are being sold for higher price, and they are bargaining. Why can't health workers? So this is one way we should look at how can health workers also bargain to see how best we can, because of our weight. Footballers are using their skills. They are getting more. So why can't we also use our skills to get more? So these are some of the things that one has to really talk of. So these are some little bit that I can say about all this brain drain to stem it up. Thank you.
Yeah, I don't want to be talking all the time. But okay. I spoke about key populations, who they are, and what, as private practitioners, we should be doing to serve them better. Key populations are female sex workers, men who have sex with men, people who use drugs. If you have a facility in the city, it's likely that you may be serving one of the members of these communities, and we should be able to respond to their needs, and that's what has led to the many discussions. I will just add one thing to what we have discussed, that there's what we call index testing. When self-disclosure or assisted disclosure is not taking place. Index testing means that that man you spoke about, you should find a way to make sure that he can be tested. He'll go have a testing done, and then he can be put on treatment. And that can lead to disclosure. I'll leave the slides so that we can. Thank you, Bro.
Thank you so much, and thank you, everybody.
I asked Dr. Nagai whether shea butter is a lubricant. I've been asked this question, so since you are here.
Yes. Yes. No. Condoms, water-based lubricants are the best. That's why you have to use water-based lubricants. If you use oil-based, then you can have breakage and there can be problems. But the good thing is that depending on the individual sexual orientation, lubricants are very important to prevent transmission. So yes, if you don't have the water-based, then you have shea butter. Yes, it is. It's therefore. But if it is oil-based, you can have breakage. That is it.
Right. Thank you. We can go on and on and on, but we'll discuss more over cocktail. Mr. President, thank you so much. You're also going to provide us with a cocktail. I wish to a full dinner so that we'll really satisfy ourselves. But I must say that the attendance is quite encouraging. We should try to make the private sector very powerful. Because if you don't, the public will cheat us. I know the public, a lot of people retire on their salaries. You have worked so much, you haven't retired on your salary. Now you are coming back to do private practice. So we should have our due. It is better to have a lot of collaboration. So this afternoon section is termed collaboration. Let us all collaborate with each other and let us all gain. Thank you so much for coming.
We are about to close. After this session, there will be a cocktail. So don't go away. Don't go yet. There's going to be a cocktail. Now, Mr. President, to give you the closing remarks.
Okay, colleagues, senior colleagues, good evening. Please lend me your ears just before we step out. I'm trying to do two things here at the same time. You've been welcomed already, and the chairman for the occasion also showed appreciation. I'm trying to do the two together, just on behalf of council, to show appreciation for your presence here. You've made it worthwhile so that all our planning and investment wouldn't go to waste. We have some new members amongst us that I would like to introduce. I mean, I can say that as we are all gathered here, we have representatives from all the 10 regions of Ghana. And some may be new to us, so I'll just we can't introduce everybody. Maybe at cocktail, I'll encourage the new ones to introduce themselves or make friends with the older colleagues. So from Northern Region, our chairperson is here, the person of Dr. Sheila Isahaku Tibaga. There she is, yeah. From Upper East Region, Boga, we have two doctors here, Dr. Duku Amia and Dr. Razak. Is it Dokurugu? I hope I got it right. You're welcome. From Boga. From Upper West, our doctor is also the GMA chairman for Upper West Region, Dr. Muslim Donko. Yeah, you're welcome. So other people from outside Accra I want to welcome is Dr. Mankwa from Sunyai. You're welcome. I think you're the only one here. Dr. Ejopon is not here yet. Okay. My immediate boss from Kumasi. Yeah, Dr. Taria, you're welcome. From Central Region too, we have Dr. Somoa. I said Taria. Dr. Somoa from Central Region. Who are the Central Region people? Yeah, you're welcome. Eastern Region, Dr. Sumeni. Dr. Sumeni from Eastern Region. You're welcome. Western Region, Dr. Gali. You're welcome. Yeah. Volta Region, Dr. Da. I don't think he's here yet. Maybe you might see him tomorrow. Volta Region, our Volta Region chairman is not here. Okay, so you're all welcome. We'll be having our cocktail in the other block. There's a hall there that has been arranged for us that we want to have our cocktail. Sir, you want to make a comment?
The retired doctors, the retired doctors have an association, retired doctors, whether if you are 60, you are retired. Whether you are working or not, you are retired. That's the point. So you have doctors retired association, which are registered. They have a platform where they share ideas, and I would like those who are interested to really. I think it's very. This is not a place we're talking about what they call TUC business, actual things which are some scientific data, and those. I think if you can give your number, telephone number, and you want to, then you put it on it. That's what I want to say. Thank you.
Central, we didn't hear. You're welcome. Another Central Region. Okay. All right. So we'll have a cocktail and then council meeting. We have a council meeting today. It was supposed to be 7, but I think we can do it earlier. 5:30. Council members will meet, all regional chairpersons and their secretaries and national executive and also committee heads. They form the council. So 5:30, we'll have that meeting. Probably within an hour, we close. Thank you all very much. Thank you.